Welcome guys. So we are going to discuss in this video lecture from Harrison 22nd edition, which is the newest edition about this Harrison chapter number 143, acute meningitis, right? So this is very important topic to manage in medicine, and you should know how to approach these cases. All right. So coming to this topic, so it is absolutely designed from 22nd edition of the Harrison, which is the newest edition, launched just few months back only and available in market. So coming to the meningitis part, now this meningitis can be mainly due to bacterial infection. It can be due to tubercular infection, viral etiology, fungal etiology, or sometimes etiology cannot be identified at all, and which we call to be aseptic meningitis. Okay, all right. Now, coming to the topic, most important thing that you should know before and going in detail about the topic is that what is meningitis and what is meningoencephalitis or encephalitis. Look, meninges form the protective shade or protective layer around the brain. All right. So when there is inflammation around the meninges, which is the protective covering in the brain, it is known as meningitis. And whenever there is involvement of brain parenchyma, or in a better term, easy term to say brain itself, it is known as encephalitis. Now, in clinical practice, meningitis and encephalitis can go hand in hand together and occur in the same individual together at the same point of time too. But for clinical differentiation, meningitis is something where when there is inflammation of meninges only, that is there will be sign of meningeal inflammation. What are the signs of meningeal inflammation? There will be headache, neck rigidity. Neck rigidity is the hallmark sign of meningeal inflammation, and some specific signs are there which can be elicited. Okay, and what are the signs when there is involvement of brain parenchyma? When there is involvement of brain parenchyma, there will be seizure, there will be focal onset neurological deficits. So encephalitis will have seizure and focal onset neurological deficit, whereas meningitis will have signs of inflammation. Inflammation sign to say like fever, headache, nausea, vomiting, along with rigidity in the form of neck rigidity. All right. So coming to the topic, this bacterial meningitis, it is the most common form of suppurative CNS infection. All right. Now, it is nothing but acute pus forming. That's why we call it to be purulent. Acute purulent infection within the subarachnoid space. Okay. So infection within the subarachnoid space. All right. Okay. So it is associated with CNS inflammatory reaction that may result into decrease in consciousness, decrease in level of the consciousness in the patient. Sometimes seizure can be seen. Sometimes there will be signs of raised intracranial pressure, and sometimes stroke-like episode can be there too. Okay. So these meninges, subarachnoid space, and brain parenchyma all are frequently involved in the inflammatory reaction. Then in such cases we call it to meningoencephalitis. All right. Okay. So coming to the causative agent, so organisms which are responsible for causing such inflammation in the brain, among which most common one is Streptococcus pneumoniae. All right. So it occurs as a most common etiology, single most common etiology in adult more than 20 years of age, as it has been mentioned in the Harrison. So around 50% of the case in adult group with 20 years of age, Streptococcus pneumoniae forms the primary pathogen. Risk factor includes pneumococcus infection any other place of the body. So it can be pneumococcal pneumonia, it can be sinusitis, otitis media, or patient with alcoholic history or prolonged diabetes. They are the person with risk who can catch this streptococcus pneumonia related meningitis. Okay, so what are the risk factor? So risk factors are: number 1, Streptococcus pneumoniae related community acquired pneumonia. Number 2, otitis media or sinusitis. Number 3, there can be other causes of like risk factor which predisposes to this condition, like diabetes or alcohol. As it is a capsulated organism, so splenectomy predisposes to this infection as well. So similarly, deficiency of complement will also increase the risk. Besides, decrease in level of gamma globulin, so hypogammaglobulinemia, gamma globulin low. Okay, so these are the risk factors which leads to this Streptococcus pneumoniae associated meningitis, and remember, it is very high mortality. Mortality can be high as more than 20%. All right. Okay. Now coming to the second most common in adult age group is Neisseria meningitis. Okay. So this incidence lately has been reduced with the use of the vaccine. So which vaccine is used? We use currently quadrivalent vaccine for it, and the quadrivalent vaccine which is used is acting against A, C, W135, W135 and Y serogroups, okay, as well as serogroup B vaccine, okay. So currently, beside this, along with this, we often add, this is known as quadrivalent, we often add B to it plus B serogroup, which make it to be pentavalent vaccine. So with the advent of quadrivalent or pentavalent vaccine, the incidence of Neisseria meningitis related pneumonia has declined very much in recent years. But nevertheless, patients with complement inhibitor therapy or complement deficiency are still at risk and form the largest group of this infection. So complement deficient people are still the largest effect group. Okay, so this meningitis often form, Neisseria meningitis often form colonization in the nasopharyngeal pathway. All right, so they form an asymptomatic colonization in nasopharyngeal pathway, and people turn into asymptomatic carrier who can turn into leads to passage of this infectious agent to different individuals, and who are predisposed will lead to invasive disease. Okay, so remember this vaccination, although it has reduced the total incidence of meningitis, but it has not reduced the carrier rate. Why so? Because there is no herd immunity associated with this vaccine. Therefore, there is no decrease in carrier rate along with the vaccine. Okay. So, clinically, when do we suspect meningitis, Neisseria meningitis? When there is petechia, purpuric rash, or fulminant presentation in a suspected case of meningitis, like headache, nausea, vomiting, and fever, and neck rigidity is present, in such cases, you suspect it to be Neisseria meningitis. So, it is so much bad prognostic is that death can occur within hours. Okay. Okay. So, coming to the next agent that I would like to talk about is Listeria. So, Listeria is usually seen in neonates. It is seen in neonates. In medicine, the age group in which Listeria is more common is in the pregnant females, or people who are more than 60 years, or immunocompromised. Okay. So, Listeria related meningitis usually is transmitted when there is foodborne contaminated milk, cheese, or like milk product, which leads to this spread of the Listeria meningitis. Okay, so through foodborne method, it gets spread, mainly milk containing product. Regarding Haemophilus influenza type B, so again, similarly to Neisseria meningitis vaccine, with advent of Haemophilus influenza type B vaccine, there is decrease in total incidence. Okay, so there is decrease in total number of incidents with the advent of vaccine. Still currently we get lot of cases of non-HB, non-H influenza B type meningitis cases. Okay. Now, Staphylococcus aureus and cons related meningitis is more common in post neurosurgery cases, mainly one with Ommaya reservoir. All right. Okay. Now, coming to the pathophysiology. So, coming to the pathophysiology of it, thing that I would like to discuss here is how these organisms, different etiological organism, leads to the disease process in the patient. Okay, so remember there is some initial triggering event and some agent, host, and environment. Agent, host, and environment interplay which leads to the disease process. So, what is the first step? First step is colonization of nasopharynx, which later in favorable condition, this agent invades the blood, maybe by epithelial vacuoles or tight junction. By passing through them, it invades the blood and forms a polysaccharide coated capsule against it, which evades the neutrophil and complement system. When it crosses the blood-brain barrier, it comes into the CSF. Now, CSF, remember, if you look at the normal study, WBC will be low in CSF. Because WBC is low, complement are also low in CSF. Therefore, CSF per se naturally is immune poor. Okay, so immunity in the CSF is low because WBC normally naturally is low. Therefore, as CSF is low immune, this bacterial agent survives in the CSF and there is rapid multiplication. Okay, and it produces different inflammatory product due to different bacterial lysis, like products like LPS, teichoic acid, peptidoglycan, then cytokines like TNF alpha, interleukin beta. These are produced, which are released within hours, resulting into increase in protein content in CSF and increase in WBC content in CSF. Okay. Now, all of those shows the effect. How? By causing edema and increasing ICP. So, TNF alpha, interleukin beta increases the blood-brain barrier permeability, resulting into vasogenic edema. Okay. Now, due to inflammation, there are exudates mainly in the subarachnoid region. So, this subarachnoid exudate resulting into obstruction of the flow of the CSF. So as there is obstruction of the flow of the CSF, there will be chance of hydrocephalus. So hydrocephalus formation is seen, which causes interstitial edema. All right. Now there will be neutrophil degranulation, as well as because of the increase in WBC, there will be neutrophil coming into play, and neutrophil gets degranulated. When they get degranulated, the resulting action is cytotoxic edema. So what is the ultimate outcome due to these three different pathways of edema formation, that is vasogenic edema, interstitial edema, or cytotoxic edema? Final outcome is raise in ICP, coma, and sometimes leading to the death. Okay, so this is the usual final outcome. It can be seen in this chart beautifully, as has been shown in Harrison. So by any means, there is invasion of subarachnoid space by meningeal pathogen like the bacteria. So this bacteria, bacteria invades. So this bacteria survives the condition in the CSF because CSF is WBC poor and low immune status. So this bacteria survives and multiplies very quickly. So it multiplies very quickly in the CSF, and during lysis, release of bacterial cellular component like endotoxin or teichoic acid is seen, which produces inflammatory cytokine. All right. Now, what is the effect of production of inflammatory cytokine? So, as you can see here, there is alteration of blood-brain barrier permeability resulting into vasogenic edema. Then, there is degranulation of the neutrophils, which leads to cytotoxic edema. Okay. Then, as there is increase in exudate, this exudate obstructs subarachnoid space, resulting into obstructive and communicating hydrocephalus, causing interstitial edema. So all of this together, all of this pathway together result into increase in intracranial pressure and ultimately to state of coma. So that's all regarding the pathogenesis of meningitis. Okay. Now coming to the clinical feature. So as you can see, clinical feature can be divided into different parts. So first of all, if we see this acute bacterial meningitis, it can be divided into two types based on the presentation, either acute fulminant presentation, number one, or subacute presentation. Subacute presentation. Acute fulminant presentation had rapid progression within hours, and subacute presentation progresses over several days. All right. Now there is triad. So triad is fever, headache, and nuchal rigidity, which is seen in this case. Now regarding signs of meningeal irritation, obviously we will get carnic sign. I will come into this obviously. Carnic sign, Brudzinski sign, Brudzinski sign, and nuchal rigidity. Nuchal rigidity is considered as pathognomic feature of meningitis, right? Now, other common clinical feature which can be seen in such cases, apart from this fever, headache, and nuchal rigidity, is altered behavior. Altered behavior. It is almost seen in 70% of the cases. Then there can be nausea, vomiting, and photophobia too. Seizure is seen in around 15 to 40% of the cases. Why so? So seizure is mainly of two types which can be seen, either focal seizure or generalized seizure. Look guys, while managing this patient of meningitis, there is high chance of electrolyte abnormality and most common being of hyponatremia. So hyponatremia leads to generalized tonic-clonic seizure. Okay. So besides this status epilepticus can be also seen due to the drug toxicity while managing the patient, or there is generalized state of anoxia or decrease in oxygen supply to the brain tissue will lead to GTCS. Okay, generalized tonic-clonic seizure. Now focal onset seizure can be seen in such cases mainly due to edema formation due to different pathways and due to venous thrombosis, which is very high chance in such cases, cerebral venous thrombosis, or due to infarct. Raised ICP, we have already discussed. Raised ICP is seen due to vasogenic edema, cytotoxic edema, and interstitial edema. So, raised ICP will lead to what are the signs? Mainly the Cushing reflex will be seen in due to raised ICP. So, Cushing reflex will be seen due to raised ICP in meningitis patient. Okay. Now, coming to other thing that I would like to discuss here is main thing that is about the signs of meningeal irritation. So what are those? Those are nuchal rigidity, kinetic sign, and Brudzinski sign. Look, it is not specific for meningitis. It only suggests there is meningismus going on. So nuchal rigidity is something considered as pathognomic feature. So when you try to flex the head, there will be difficulty while flexing because of the rigidity there. Now kinetic sign, as you can see here, so there will be pain while trying to extend the knee while hip being flexed. So while hip being flexed, when you try to extend the knee of the patient, this will elicit a pain on limited extension. This is known as kinetic sign. Brudzinski Brudzinski sign. Brudzinski sign is when when you try to passive flexion of neck, there will be hip and knee flexion as well. So passive neck flexion resulting into hip and knee flexion is known as Brudzinski sign. Remember, these two signs, although studied a lot, but have limited sensitivity and specificity because they can be absent in elderly and immunocompromised state. Okay, all right. Now coming to the diagnosis part. So how do you make diagnosis of the case? So remember, whatever this is, if your provisional diagnosis is meningitis, first step involves immediate antibiotic therapy, empirical antibiotic, preferably within 1 hour. And what you should do before giving antibiotic? Collect blood culture. Okay, collect blood culture. Along with antibiotic, you need to give dexamethasone. Dexamethasone should be given ideally 20 minutes prior prior to antibiotic. Okay, prior to antibiotic. Now, next step involves after giving antibiotic is to make a proper etiological diagnosis, like what sort of infection it is, whether it is bacterial infection, viral infection, fungal infection, or aseptic causes. So how do you make the diagnosis? You check for the lumbar puncture. So it is safe without neuroimaging if immunocompetent, normal consciousness is there, or no papilledema or focal deficit, or no recent trauma history. Now, Now, sometimes there can be raised ICP feature. In such cases, it is better to go for neuroimaging first, followed by lumbar puncture. Okay. So, what will do the lumbar puncture report will show us in case of classic bacterial meningitis, white blood cell will be more with neutrophil predominance. That is, polymorphonuclear neutrophils will be the maximum percentage, maybe around in 90% cases. Okay, up to 90% of the white blood cell can be PMN cells. Now, this bacteria will take glucose for its metabolism. That's why glucose level will be low, less than 40 milligram per DL. So, CSF glucose less than 40 is considered to be abnormal. So, we often what we do is to check CSF glucose to blood glucose level. A ratio of less than 0.4, ratio of less than 0.4 is highly suggestive of bacterial meningitis. It can be also seen in TB, fungal or carcinomatous meningitis as well. Now, remember, if the patient is hypoglycemic and you have treated with dextrose, acute treatment with glucose therapy will not change the CSF picture unless time have passed a lot, like 3 to 4 hours has passed after acute IV glucose therapy. Okay, so that's the pitfall that you should keep in mind while interpreting the glucose level in case of meningitis patient. Now we have developed some other investigation methodology beside protein which will be higher, and opening pressure obviously will be high, more than 180 in case of bacterial meningitis. We have developed advanced diagnostic test in the form of multiplex PCR. So this multiplex PCR detects the bacterial DNA. So it is also given the name of biofilm or film array or biofire. Okay, so it detects Streptococcus pneumoniae, Neisseria meningitis, E. coli, Listeria, Haemophilus influenzae, which are the more common causes of acute bacterial meningitis. But its limitation include current technology is not available to diagnose Staph aureus, coagulous negative cases, or many gram negative cases. For which culture and sensitivity is still required. For which culture and sensitivity is still required. Okay. Now, regarding neuroimaging, remember MRI is better than CT, and there will be finding of diffuse meningeal enhancement, which is although non-specific but gives a potential clue for diagnosing those cases. Remember, if this is a case of meningococcemia, so skin biopsy can be done from the petechial rashes, which may reveal the organism on gram staining. All right. Okay. So that's all how we are going to diagnose the case. Next, once we made the diagnosis, always we need to keep in mind what are the differentials of the cases. Okay, so differential of these cases, what I would like to keep in mind is obviously viral meningoencephalitis. Mainly viral meningoencephalitis is due to HSV virus. So what is the usual picture of HSV encephalitis? Usual picture is headache, fever, altered consciousness. Because it is encephalitis, there will be focal deficit. Focal deficit can be dysphagia. There can be hemiparesis like picture. There can be seizure. Seizure can be focal or generalized tonic-clonic seizure development in this patient. Okay. Now CSF will give the biggest clue for diagnosing these cases. So lymphocyte will be more. Lymphocytic predominance can be seen in these cases, whereas neutrophil predominance is seen in bacterial meningitis, and lymphocyte predominance with normal glucose. Okay, normal glucose will be seen. Now, specific diagnostic test, if I say, we have CSF HSB PCR test, CSF HSB PCR test, which is sensitive in 96% cases, okay, and specific in 99% cases. So this CSF HSB PCR is best done if it is done after 72 hours of onset of symptom. All right, onset of symptom. Okay. Now MRI will also reveal high signal lesion in orbitofrontal region, anterior and medial temporal lobe region, and MRI is best done within 48 hours. Okay. So that's about viral meningoencephalitis, HSV encephalitis per se, which I would like to keep in differential. Next differential that I should like to keep is rickettsial disease, mainly Rocky Mountain spotted fever. All right. Now, besides that, there are some other causes of focal suppurative CNS infection. For example, subdural ependyma, epidural empyema, and brain abscess, which can have similar presentation. Now, non-infectious causes which can mimic this acute bacterial meningitis include subarachnoid hemorrhage, then it can be medication induced causes, or 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 it can be due to carcinoma related causes too. Carcinoma related causes. Okay. All right. Now, after discussing all of those diagnostic modality, differential diagnosis, clinical features, we are coming into empirical therapy. So what is the principle of therapy that I want you should know? Principle of therapy. So principle of therapy for us is, this is a medical emergency, right? So antibiotics should be started within 60 minutes of arrival and start empirical therapy before the CSM present. So while guiding the empirical therapy, remember the most two common pathogen for us is Streptococcus pneumoniae and Neisseria meningitis. Okay. So we'll give a base regimen for community acquired bacterial meningitis. All right. So we'll give a base regimen for it. So what are the things that we need to give? Remember, we need to give dexamethasone for CSF penetration just before antibiotic. So we can give around 20 minutes prior to antibiotic therapy. Choice should be third and fourth generation cephalosporin. Mainly, we can give ceftriaxone or cefepime. Cefepime is better choice if we suspect to be hospital acquired infection, because cefepime also cover pseudomonas. But issue with cefepime is that it can itself lead into myoclonus or encephalopathy like picture. So it should be used with caution, and its limitation should be only in critically ill patient, only not in semi-critical patient. We should not use cefepime. Okay, we should better use ceftriaxone for them. Besides ceftriaxone, third choice that medication needs to be given is vancomycin. Okay, so vancomycin, it is for resistant Streptococcus pneumoniae infection. Then acyclovir should be added for HSV encephalitis coverage, and along with that we need to give doxycycline. Doxycycline is during the tick season for rickettsia and tick-borne illness. So whenever a patient is coming to you, first thing that you need to do is start dexamethasone 20 minutes prior to giving antibiotic. Start with third or fourth generation cephalosporin. So third and fourth generation cephalosporin can be ceftriaxone, cefotaxime, or cefepime. So best choice is ceftriaxone. So if you suspect pseudomonas infection, maybe some sort of hospital acquired infection you're suspecting, in such case you can give for cefepime. But beware before starting cefepime, because cefepime itself causes myoclonus, itself causes encephalopathy or seizure. So sometimes it can mimic with the condition itself. All right. Now besides cefepime, besides ceftriaxone, we need to go for vancomycin. Vancomycin, why? Because if it is a case of resistant strep pneumonia, in such cases we need to give for vancomycin. Acyclovir for coverage of HSV encephalitis. If patient present with encephalitis like picture, in such cases acyclovir should be added, and doxycycline. So once you've started all those parameters, covered all those parameters in treatment regime, the base regime, then you need to modify accordingly. So what are the modification that we can go for? For example, if it is suspected to be case of Listeria, in such cases ampicillin can be added. So when is Listeria coverage suspected? When age is less than 3 months or age is more than 55 years, or the patient is immunocompromised. Suppose the patient is transplant candidate or chronic illness, pregnancy, malignancy associated cases. In such cases, ampicillin coverage should be given. Now, metronidazole coverage can be added plus minus if we want to give anaerobic coverage. When do we need to give anaerobic coverage? When we suspect to be otitis, sinusitis, or mastocytitis. So, otitis, sinusitis, or mastocytitis, we need to give for metronidazole cover. And if Listeria is suspected, in such cases, ampicillin coverage should be given. Okay, all right. Now, in case of hospital acquired cases, or some, for example, if it is a case of post neurosurgical meningitis, so likely organism in such cases are staphylococcal, which are usually resistant, or gram negatives like pseudomonas. How do you treat them? In such cases, treat with empirical regime in the form of vancomycin plus meropenem. Okay, so we often avoid ceftriaxone or cefotaxib in such cases because it has less penetration against pseudomonas. So meropenem is a very good choice for pseudomonas coverage. Sometimes we can give ceftazidime too. So remember meropenem has very good cover against Listeria, pseudomonas, or penicillin resistant strain of strep pneumoniae. So in pneumococcal meningitis, it is similar to ceftriaxone but less effective than vancomycin for safe sterilization. That's why in pneumococcal strep pneumonia meningitis, we don't use in initial stages meropenem. We better use ceftriaxone in it, and along with it, we give vancomycin. And one thing you should remember while giving meropenem is that it should not be never used as monotherapy. It should be always used with a combination therapy. Okay, all right. Now, once we have started empirical therapy based on the profile of the patient and suspicion of the patient condition, we need to go for specific antibiotic therapy. So, specific antibiotic therapy, for example, for Neisseria meningitis cases, which causes meningococcal meningitis, empirical is ceftriaxone or cefotaxime. All right. Now, if the strain is penicillin sensitive, in such cases, we can go for penicillin G. Now, duration of this therapy is usually 7 days, IV therapy. And remember, it's do spread, Neisseria meningitis can spread among close contact. Therefore, close contact should receive rifampicin for 2 days. Alternatively, azithromycin 500 milligram stat dose can be given. Why so? Now, rifampicin are contaminated in lot of cases like pregnancy, and rifampicin has lot of drug interaction. So, in such cases, we can directly go to alternative agent like azithromycin 500 milligram stat dose, or ceftriaxone if we want to go for IV 250 milligram IV stat. Okay. Next we have Streptococcus pneumoniae. So Streptococcus pneumoniae, empirical drug should be given. Empirical drug in the form of cephalosporin, which can be ceftriaxone, cefotaxime, or cefepime, plus vancomycin should be added. Now it should be adjusted based on minimum inhibitory concentration. So penicillin minimum inhibitory concentration for penicillin is less than 0.06. It is considered as susceptible, and more than 0.12 is considered as resistant. For cephalosporin, ceftriaxone or cefotaxime, minimum inhibitory concentration is less than 0.5, which is considered to be sensitive, and more than 2 is considered to be resistant. So less than 0.5 is sensitive, more than 2 is considered to be resistant. All right. Now, this duration of pneumococcal meningitis treatment should also go for around 2 weeks, and repeat lumbar puncture at 24 to 36 hours to check for CSF sterilization. If there is persistent infection, in such cases we need to go for intraventricular vancomycin. All right. Okay. So, if Listeria monocytogenes infection is suspected, we need to give ampicillin to the patient, and gentamicin is added if the patient is critically ill. Duration of therapy is around 3 weeks. All right. Okay. So, if it is penicillin allergy, in such cases we can go for otrimoxazole, that is trimethoprim and sulfamethoxazole therapy. In case of Staphylococcus species meningitis, so in methicillin sensitive cases, which we also call to be CONS, coagulose negative cases, drug of choice is nepenicillin, and methicillin resistant or MRSA, in such cases drug of choice is vancomycin. So similarly, in MRSA where vancomycin is started, you need to check for CSF after 2 to 3 days and check that is mean in resistant infection, you need to check CSF whether their sterilization is happening in 2 to 3 days or not. If not, intrathecal or intrathecal vancomycin should be given. Vancomycin should be given. Okay. So if gram-negative bacilli meningitis is suspected, cefotaxime, ceftriaxone, or ceftazidime is the choice. For pseudomonas cases, we choose is ceftazidime or meropenem. Duration of therapy of pseudomonas is 3 weeks. Okay, that is the specific antibiotic therapy we need to give. Now coming to very important topic, most important topic, what is the role of dexamethasone? So dexamethasone acts as adjunctive therapy, to the primary treatment. It reduces the interleukin, mainly interleukin 1 beta, TNF alpha, and it reduces meningeal inflammation and sequelae of meningitis like hearing loss, neurologic damage. All of this sequelae is reduced. Most beneficial in strep pneumonia infection. Strep pneumonia infection, it is the most beneficial. So in adult trial, it has been found there is reduced unfavorable outcome and mortality with use of dexamethasone. So usual dose which is used is 10 milligram IV QID for 4 days. Okay, it should be given 20 minutes before or with fast antibiotic dose itself. So there is no benefit if started, limited benefit if started more than 6 hours of antibiotics course. Okay, and concern with dexamethasone is that dexamethasone decreases the vancomycin penetration into CSF. So for use of dexamethasone along with vancomycin, we need to give high dose vancomycin. Okay, or we need to check for the intraventricular role. So use high dose vanco around 45 to 60 milligram per kg of vancomycin should be given in such cases. And there is no proven benefit in low income countries, because low income countries like India, in our countries, there is of a late presentation, or the patient is malnourished enough where we cannot give dexamethasone. Okay. Besides this, what are the adjunctive therapy we need to go for? Adjunctive therapy that we need to go for is like increased intracranial pressure management. So how to manage the increased intracranial pressure? Elevate the head by 30 to 45 degree, intubate the patient and go for hyperventilation, like permissive hypercapnia can be tried, give monitor, or patient might need ICU care with intracranial pressure monitored. So that's all regarding acute bacterial meningitis. In our next module, we'll look into the viral meningitis and other types of meningitis and how to approach them.